We're going to look at the regulation of stroke volume. And there are three main factors affecting stroke volume. Preload, which is the initial stretching of the cardiac myocytes or muscle cells prior to the contraction. It is related to ventricular filling. And then there's contractility. It's the intrinsic strength of the cardiac muscle independent of preload, but a change in preload will affect the force of contraction. And then afterload, which is the force or load against which the heart has to contract in order to eject blood. So we're going to look at all of those in more detail in the following slides. For example, preload, degree of stretch of the heart muscle. If the heart stretches more, we're saying that we're loading more blood into the heart before ventricular ejection. So if we kind of just elaborate on that, preload is the degree to which cardiac muscle cells are stretched just before they contract. So changes in preload cause changes in stroke volume because it affects EDV. The relationship between preload and stroke volume is actually called the Frank-Starling law of the heart, which is just the relationship between EDV and stroke volume. Because when EDV increases, which may be affected by changes in preload, stroke volume increases. Cardiac muscle cell actually exhibits a length tension relationship because at rest, cardiac muscle cells are shorter than optimal length, and this leads to a dramatic increase in contractile force if they are stretched prior to ventricular contraction. The most important factor in preload is definitely the stretching of cardiac muscle cells via venous return. Venous return is the amount of blood returning to the heart, and if you can increase the amount of blood returning to the heart that then flows into the atria and then finally the ventricles, you can increase the stretch of cardiac myocytes. A slow heartbeat, increased exercise, both of these things increase venous return. And increased venous return distends or increases preloads because we stretch the ventricles and increase, therefore, contraction force. So we can see that in the following equation. Increased venous return leads to increases in cardiac output. This connection is possible via the Frank-Starling law of the heart, where increased EDV leads to increased stroke volume. Next, let's look at contractility. Contractile strength at a given muscle length is readily established by looking at kind of how do cardiac myocytes contract, which we've done prior. We know that contractility is independent of muscle stretch, independent of EDV or in diastolic volume, but increased contractility does lower ESV, and that's caused by sympathetic epinephrine release. And the sympathetic epinephrine release is epinephrine release from the adrenal medulla, and that causes increased calcium influx from outside the cell and can lead to more calcium release from the sarcoplasmic reticulum inside these cardiac myocytes, which leads to more cross-bridge formations. Any chemical that causes an increase in contractility is termed a positive inotropic agent. This includes high extracellular calcium levels, thyroxine, glucagon, and epinephrine and digitalis. Any chemical that decreases contractility is deemed a negative inotropic agent. These include things like acidosis or increased extracellular potassium, even calcium channel blockers, because they're doing the opposite of that sympathetic epinephrine release. Here's an example of sympathetic norepinephrine and epinephrine release from the adrenal medulla. Here we see norepinephrine specifically binding to a beta sub-1 adrenergic receptor in the plasma membrane of this cell. This is going to activate a secondary messenger system, leading to the production of the secondary messenger cyclic AMP, which turns on protein kinases. These protein kinases lead to increased calcium entry from extracellular fluid by opening these calcium channels in the plasma membrane, and they lead to increased calcium release from the sarcoplasmic reticulum by opening calcium channels in the sarcoplasmic reticulum. Both of these extra calcium ions are added to the cytoplasm of this cell, and that leads to an increase in force of contraction because calcium is a positive inotropic agent. And finally, we want to talk about afterload in more detail. Afterload, again, is that back pressure exerted by arterial blood. Afterload is pressure that the ventricles must overcome to eject blood. So hypertension or high blood pressure increases afterload and can result in increased ESV, or amount of blood left over after ventricular ejection in the ventricles. That would reduce stroke volume. Aortic pressure is generally around 80 millimeters of mercury, and the pulmonary trunk pressure is around 10 millimeters of mercury. So normally this back pressure is able to be overcome by ventricular contraction. But say stroke volume decreases as a result of decreased blood volume or a weakened heart. That would affect cardiac output. So we would need some way to maintain cardiac output. What happens is we can maintain cardiac output in the case of a stroke volume decrease by increasing heart rate and contractility. If we wanted to increase heart rate, we could use a positive chronotropic agent because these factors or chemicals increase heart rate when acting. Whereas a negative chronotropic agent would be a factor that decreases heart rate. Things that can increase heart rate would be the regulation by autonomic nervous system functions, chemicals, and other factors. The autonomic nervous system regulation of the heart rate is done primarily by the two arms of the ANS, the sympathetic and parasympathetic nervous systems. The sympathetic nervous system can be activated by emotional or physical stressors, and one of the hormones it would release, or a chemical that would act as a hormone, is norepinephrine from the adrenal medulla. We saw this in a prior slide where norepinephrine bound to a beta-1 adrenergic receptor on the heart, and this caused the pacemaker to fire more rapidly. Pacemaker meaning the SA node. This would increase heart rate, and EDV would be decreased because of decreased fill time. We also would see increased contractility because ESV decreased because of the increased volume of ejected blood. In this case, both EDV and ESV decreased at the same time because we increased heart rate. And if both EDV and ESV decrease, we actually have no change to stroke volume. Keep in mind that the parasympathetic nervous system opposes any sympathetic effects. They work in dynamic antagonism, and acetylcholine is going to be a chemical that could be released by parasympathetic neurons, and it would generally hyperpolarize or inhibit pacemaker cells, such as that of the SA node, by opening potassium channels, and that would slow heart rate. Remember, potassium was an efflux, whereas we would want either a sodium or calcium influx if we were trying to increase heart rate. And we would see that parasympathetic nervous system action has actually very little to no effect on contractility. The heart actually exists in a condition we're going to call vagal tone, or it exhibits at rest this vagal tone, which is paramount due to autonomic nervous system regulation, or exists because of, we'll say, autonomic nervous system regulation. And the part of the autonomic nervous system that creates vagal tone is the parasympathetic nervous system. It's the dominant influence on heart rate. It actually decreases heart rate by 25 beats per minute because it acts on the SA node to bring down kind of the innate rhythm of the SA node of 100 beats per minute down by that 25 beats to sinus rhythm of 75 beats per minute. Vagal tone is talking about the vagus nerve. The vagus nerve is a parasympathetic nervous system neuron. Let's also talk about the fact that when the sympathetic nervous system is activated, or we could say stimuli from the sympathetic nervous system are more active on the heart, that means that the parasympathetic nervous system is inhibited, and vice versa. We can also mention the atrial Bainbridge reflex. It's a sympathetic reflex. It's initiated by increased venous return. It's called the atrial reflex because we're looking mainly at the increased atrial filling. But this venous return would actually also then affect the ventricles. But the atrial reflex is talking about how when atrial walls are stretched, that increased volume will stimulate the SA node and make the SA node fire earlier than it normally would. And that would increase heart rate. Because remember, the SA node or sinoatrial node is the pacemaker of the heart. This would also stimulate atrial stretch receptors that activate sympathetic reflexes, and the sympathetic reflexes are going to increase heart rate as well. So kind of a two-punch there. And here is figure 17.20 again, looking at the factors involved in determining cardiac output. Pay attention to the green physiological responses. Understand the definitions for stroke volume, heart rate, and cardiac output. Words like EDV, ESV, and increased sympathetic nervous system activity should not be throwing you off. Understand how increased contractility is lowering ESV, or how increased venous return is increasing EDV. EDV is essentially preload, whereas things like afterload and contractility may take a little bit longer to understand. EDV and preload are essentially the same thing, so that's a little easier. And preload is really just how much are we stretching or how much are we filling the heart. So please review figure 17.20 and all the factors therein that go into explaining this chart. You should also know the mathematical formulas for stroke volume and cardiac output, so make sure to spend time in this particular section of the chapter. Let's continue on though and look at the chemical regulation of heart rate. There's hormones like epinephrine and thyroxine, which can affect heart rate. Epinephrine can affect heart rate and contractility. Thyroxine works with norepinephrine and epinephrine to increase heart rate. Ions like calcium and potassium, they're required for regular depolarizations and repolarizations. Calcium especially for the plateau phase that we find in the action potentials of contractile cells that's in the heart. So imbalances of ions are very dangerous to the heart. For example, hypocalcemia depresses the heart. Hypercalcemia increases heart rate and contractility. Hyperkalemia alters electrical activity, and that can lead to heart block and cardiac arrest, whereas hypokalemia results in feeble heart rate or arrhythmias. And then other factors that influence heart rate are age, gender, exercise, and body temperature. You may already know that heart rate increases with increased body temperature. Or maybe you've noticed that when you exercise, you may experience a temporary increase in heart rate. You might not have known, however, that the fetus has the fastest heart rate, that our heart rate should decline with age. Females generally have a faster heart rate than males, so gender definitely plays a role in the regulation of heart rate as well, but a minor one. Let's also add some definitions. Tachycardia is an abnormally fast heart rate, a heart rate that's higher than 100 beats per minute. If persistence, this could lead to fibrillation. Bradycardia is a slow heart rate, a heart rate slower than 60 beats per minute. And it may not be dangerous at all, especially if you've been doing endurance training. This may be a desirable result. Bradycardia is only dangerous if it results in grossly inadequate blood circulation in non-athletes. So if you have been doing endurance training and you experience a heart rate much slower than normal, definitely get that checked out because that would be bradycardia and can be dangerous. It could cause hypoxia in tissues and tissue death. We also want to look at congestive heart failure, which is generally abbreviated CHF. It's a progressive condition, so once it starts, it tends to get worse. Treating the symptoms is generally the treatment of choice. Since it's progressive, cardiac output in congestive heart failure is so low that blood circulation is inadequate to meet tissue needs. So eventually hypoxia or oxygen starvation results in tissues, and the tissues begin to die. And congestive heart failure just reflects weakened myocardium. Really over a long period of time, congestive heart failure is oftentimes seen in the elderly. It could be due to a lifetime of coronary arteriosclerosis, clogged arteries. It could be due to persistent high blood pressure. Aortic pressure greater than 90 millimeters of mercury over a period of time can cause the myocardium to exert more force, really because it's increasing in systolic volume chronically, causing the myocardium to hypertrophy and weaken. Multiple myocardial infarctions, dilated cardiomyopathy, all associated with the development of this congestive heart failure. With multiple myocardial infarctions, the heart's becoming weak because the tissue that's dying, the infarcts, are being replaced by scar tissue. So less and less of the heart is able to actually contract, and that means the heart's weaker. Dilated cardiomyopathy, or DCM, is when the ventricles stretch and become flabby. And that means the myocardium is going to deteriorate. So the ventricles may stretch and become flabby. They're not actually, though, stretching and getting bigger and being replaced by myocardium. This actually could be caused by drug toxicity or chronic inflammation, maybe because of an autoimmune disorder. Both of those could play a role. Either side of the heart can be affected in someone who's suffering from congestive heart failure. Normally one side is affected first, but failure of either side is ultimately going to weaken the other side. Left-sided failure results in pulmonary congestion. So basically the left side's failing, so blood backs up in the lungs. Right-sided failure results in peripheral congestion. So the right side's failing, so that blood's going to back up in the tissues. That generally causes edema, especially in areas of the extremities, such as the ankles. But the failure of both sides near the end of congestive heart failure leads to kind of decompensated, a seriously weakened heart. The treatment is periodic. We're just treating the symptoms, removal of fluid from around the heart or in the lungs or in the body extremities, drugs to reduce afterload caused by high blood pressure or hypertension, and then chemicals to increase contractility in order to decrease in systolic volume.